Well, welcome. It's 11 o'clock. We might give just another minute for some participants to join us, and then we're going to jump right into our discussion today. I will tell you, it is every bit of an hour. Certainly, I've been accused of talking too quickly before, so maybe it'll be a little bit less, but it really is a chocked full hour of information. And then we'll save questions for the end. So if you are looking in terms of planning how much time we'll be together, certainly a safe bet till just about probably 12:30, depending on how many questions we have at the end. So I'm going to give it just another minute for more participants to join us, and then we'll jump right in. I do want to make a note that this is being recorded. So you will have seen that pop up on your screen. You are not visible as a participant. You will have a chance to type questions into the chat feature, the Q&A feature. But we have, because it's a webinar setup, we've disabled your visual, so you will not be on this recording. Your picture will not be on this recording. And we have this link to the recording. So afterwards, I can share that with each and every one of you. If there's someone else in your circle that you wanted to make to the webinar today and they can't, you'd be able to share that link to the recording with them. So let's go ahead and jump in. Like I said, we've got just about a full hour ahead of us in terms of information that I am eager to share with you. So today we're going to be talking about navigating assisted living and memory care. Specifically, we're going to look at the life plan difference. That's what I can share the most with you about. But before we really jump into the life plan difference, we want to just broadly look at what is assisted living level of care. So I want to introduce myself. I'm Kiersten Parsons. I'm Ingleside's Director for Healthcare Sales. What that means is that I'm the healthcare professional in our sales and marketing team. I'm able to help with our assisted living clients because this is a regulated level of care where there is inevitably some healthcare need present. So that's what I currently do. I've been working with Ingleside for the last 5 years. My career in senior living has been more than 10 years now. Working in every level of care. I started out actually at skilled nursing, which is that highest level of care. So if we think about an individual who has really acute clinical care needs, or they have long-term care needs that are at that high dependence for nursing team members, that's where I started out. So I started out in the nursing team, supporting these individuals, and then actually pursued further education to work as a clinical dietitian. Stayed in senior living. At that point, worked in all levels of care. So nutrition educational events and independent living, actually functioning as the clinical dietitian in assisted living and skilled nursing. I joined the Ingleside team, have served in that capacity. And then, like I mentioned, I'm now part of our sales and marketing team. But for the past 10 plus years, I've had the privilege of working in not just Ingleside's communities, but senior living communities across DC, Maryland, and Virginia. When I worked as a contract dietitian, I was part of many different communities in a contract capacity, which allowed me to see standalone assisted living communities, CCRC communities, many varieties. And so we'll talk a little bit more about that today. So I do want to just mention this. I think we're all pretty familiar with Zoom at this point, but if you've got a question to ask, go ahead and drop that in the chat or use the Q&A feature. And what we're going to do is save all of the questions until the end. Like I mentioned, I think it's about an hour, and then we'll have a half hour for questions. And so we can address each one of those. And it may be that your question is addressed in the presentation before we even get to the questions time. All right, so jumping right into talking about assisted living and what that means, I think it's helpful if we actually zoom out and talk first about the continuum. And so I think it's helpful if we look at independent living, assisted living, and skilled nursing. That's that continuum of care. and thinking about it as A, B, and C along this continuum. If we say that independent living is A, assisted living is B, skilled nursing is C. So looking briefly at independent living, not our focus today, but that's a social model. So we're looking at individuals who are independently choosing to live in this resort style community where they have services and amenities. And really that is the draw. It's community and it's stress-free living, right? You are not responsible for your maintenance of your appliances or of housekeeping or keeping up your lawn and grounds and all of that. It's carefree living. And that's really what independent living sells, is this services and amenities and this lifestyle, and also living in community. I mean, I think we're all social beings to some degree or another, and we want that experience. So that really is the independent living experience. Again, it's not a medical model. So certainly many communities will have maybe a nurse or a clinic on site, but that's something that you're pursuing independently, and you're maintaining your own physician groups, or even if you were to join a physician group that's in that community, you're still pursuing those appointments independently and managing your own care independently. If we skip over assisted living, so kind of point B on this continuum, and jump to point C, which would be skilled nursing. Again, that's where I mentioned in the beginning that that is where I started my career. This is a high level of care. So this is really individuals who are dependent on nursing team members. So for some portion of their activity of daily living, or potentially all of their activities of daily living, they are dependent on not just maybe one, but even up to two or more team members to care for them and help them work through those things that you and I do probably every day and maybe not even think about. And so when we talk about activities of daily living, which we will in a further slide, when we look at skilled nursing, that's a level of care where somebody is totally dependent for many or all of those needs. So you can be in that setting short term. We've all probably had someone in our life who's had a hip surgery or a knee surgery and has had to do short-term rehab. That's something that you're doing at that skilled nursing setting, some amount of weeks. You're doing intense therapy. And then the plan is to discharge to a different setting, either to home or to assisted living or independent living, wherever home is for you, that's safe and appropriate for the care needs that you now have. There's also long-term care within skilled nursing facilities. And that would mean that permanently that individual needs that much support with their activities of daily living. And that is their permanent setting. They're not discharging somewhere else. So skilled nursing has both short-term rehab and long-term care. So coming back to assisted living, we're in the middle of this continuum, maybe let's say point B, right? This is a setting where somebody is really able to participate in their care plan. And so this is an individual who they are able to participate in their activities of daily living. They need some support. They need some help. Maybe there's a specific area, one or two activities of daily living that it's really not safe for them to do by themselves. But overall, they're still wanting their own apartment. They want to host their family or their grandchildren. They want to maybe still putz around a little bit and have a kitchenette, or they want to independently go to programs on campus. So this is really a setting where someone is largely mobile, so still ambulatory might be the word that you've heard if you're caring for somebody and helping them with their activities of daily living, and you've met with a care team and they say, yes, your loved one's ambulatory. That just means they're able to walk, or if they're in a wheelchair, they can self-propel that wheelchair. So they're able to get around campus. Really, they need some support, but they're not totally dependent. That's assisted living in a nutshell. Really, the sweet spot is identifying how do we tune up independent, right? So hone in on any area that they can independently care for themselves while safely providing those support services for some of the more dangerous things that you can do when you're an older adult and you've maybe had a hip surgery in the past, right? Well, let's not shower by ourselves without a nurse at least standing outside the shower curtain, or maybe just a steady hand while you're doing that activity. But let's do some of those more dangerous things with safety. So something like medication management, it's not that you forget how to do it, but if all those pills are so tiny and your dexterity has decreased and you're not able to sort those medications, or they start to look similar to you, let's have that dangerous activity supported by a nursing professional. And so that's really a good way to think about assisted living, is that So much of what you do is independent, but you've got the right support in place to help keep you safe. When we talk about memory support or memory care, it's important to understand that that is not a level of care. So we're not talking about point A, B, or C on this continuum of care or these levels of care. Memory support and memory care is an approach. So it's best to think about it as maybe a model of care or an approach to care, but not a regulated or licensed level of care like assisted living is or like skilled nursing is. So to make that make more sense, you could be looking at a community that has memory support services or a dementia-specific approach to care in independent living. So what that looks like is a social day program where individuals who have a neurocognitive diagnosis, let's say that, for example, they have Alzheimer's disease and they have that diagnosis, they need some specific care, maybe during the day, they're still independent, they can still use the bathroom by themselves. There's so many things that they can do, kind of their medical care by themselves, or maybe their loved one guides them, but they don't need a nursing team member's help with that. So they're independent largely, but there's some need there for social interaction and care. And so that dementia-specific approach could be available at the independent living level of care through a social day program. Then we look at maybe assisted living, and you're saying, you know what, there's some need now. My loved one is forgetting to shower. That's kind of an issue of combat there. We're not showering, or hygiene's taken a hit, and we're maybe not doing that so well. There's some activities of daily living where my loved one needs some support, but they can walk still and they can talk and they want to participate in programs. And there's so much that they want to do. We don't need a nursing home, but we just need some care, but also they're still really independent. So then you're probably looking at assisted living, but a dementia-specific approach. And then, of course, there's skilled nursing. So you may say, you know what, my loved one has an Alzheimer's disease diagnosis, but that's no longer their primary diagnosis. I mean, they have XYZ other chronic diagnoses, and they are being cared for at this high level. They're dependent on others, nursing team members, for many, if not all of their activities of daily living. They are appropriate for the long-term care setting within a skilled nursing facility, but perhaps there's a floor or a specific wing that has a dementia-specific approach to that care. And so all of the individuals within that neighborhood are all within a dementia diagnosis, and they have that specific care. So the way that the team is trained and is approaching them is through that lens of dementia care. So a lot of time on one slide, but it's important that we understand exactly what assisted living is, because as we navigate these options, terminology is everywhere and it means specific things. And so it's helpful to understand, when you're doing a Google search or looking for a community, what exactly have you uncovered and what are you looking at? So I told you we'd break down activities of daily living just a little bit more. I won't spend a lot of time here, but just to say some of the things that you and I might do rather independently, don't even think about. These have all actually been categorized by physical therapists, by occupational therapists, by clinical team members to say these are the activities of daily living that we score, that we see somebody, in a day, how much help do they need with them? And so this is part of often a clinical assessment to say, how much help is needed with bathing, or do they need one or two people to help them walk? Is it just one physical therapist with a gait belt, or is it two, somebody on either side of them? How much support is needed for each one of these activities of daily living? So if you have, or if you're caring for a loved one and you've taken them to a community to do an assessment, and you've wondered, well, what makes up that assessment? This is a huge bulk of that assessment, is looking through the activities of daily living, and then how much support or care is needed, and that how much is often quantified by individuals. So one person assist or two person assist, and even just cueing would be considered one person, but not physical touch, right? So maybe you're prompting, hey, let's have a glass of water now. We haven't had anything to drink in a little while. So that person is supporting their hydration needs, but that's a very minimal level of support because it's not even hands-on. There's handing them a glass, and that's all the individual is able to take it from there. So we look at kind of this scope of maybe a scale of 1 to 4, how much support is needed, and then we look through all of these activities of daily living: bathing, walking, dressing, toileting, bed transfers, eating, preparation of meals. It kind of goes on. So there's more than just what's listed here. You see at the top, though, how prevalent it is to need support with bathing. Like I mentioned earlier, a shower can be such a dangerous activity. And when you look at assisted living, that may be one of the only things you say, you know what, I want help with showering and help with med management. And those might seem like two silly, not that significant things. They're pretty up there in terms of potential for danger and needing support with them. So let's talk a little bit more about assisted living level of care, and then how that would differ when it's a memory support approach or a dementia specific approach. So we haven't outright said it yet, but let's understand that there is an assisted living where an individual does not have a dementia diagnosis, right? So this is maybe more of a traditional model where you have an individual who needs support in some of the ways that we've already talked about, but there's no neurocognitive decline. And so maybe you've been part of this kind of school of thought where it's like, well, as everyone ages, decline starts to happen neurocognitively and it's inevitable. Well, that's not true. So clinical dementia or that diagnosis is not a normal part of aging. That's abnormal aging. And it is a very specific and separate diagnosis from just somebody who is an older adult who maybe forgets something or can't remember that 15th grandchild's birthday. You know, those are kind of normal. You might even have that diagnosis of mild cognitive impairment, really not what that means. It's just normal aging versus a clinical diagnosis of neurocognitive change that is progressive. And certainly there's many forms of dementia. That's kind of an umbrella term, but just to understand that this means two different things. So someone moving to assisted living does not automatically have memory loss or need that approach to care. And so because of that, many communities do have two specific neighborhoods: a traditional assisted living, where an individual needs support physically, like showering, like medication management, like meals. And that's not a memory approach. And then you also have a memory specific approach where that individual is receiving all of those same supports, right? So there's nursing team members who are able to help with a shower, the meals are included. So it's still the assisted living level of care, but now it's that dementia specific approach to care. And so how that changes is in these 4 bullet points. So as you're looking at communities, whether that's virtually or in person, these are things to look at and to ask about. So programming and services, that should change when you're looking at a dementia specific approach. So one of the ways, and this may sound obvious to you, is that an individual who is in a traditional assisted living can kind of have that self-autonomy to say, well, I do or don't want to go to that program, or I'm going to look at my calendar and circle that there's a fitness class at 2 p.m. Well, after lunch, I'm going to remember that I want to go do that fitness class. And so there's that kind of independence to manage their schedule, what they enjoy doing. In a memory support approach, there needs to be specific team members who are helping and cueing that individual to say, you know what, I know that you love fitness class. That was a big part of who you were, and you were always a tennis player. You know, I know this from meeting with your family. It's part of your care plan. So what we're going to do is we're going to go to this fitness class after lunch, and they go and get that person after lunch and bring them to that fitness class. And so there's that kind of, yes, the program is available in both level or both neighborhoods, but it's that added layer of cueing, verbal guidance. We even call it narrating their day to say, well, we're going to do this, and then we're going to do that. And then we come back and we do those things with them. And so that's kind of this added layer when you have a dementia approach to care that would be different from a traditional model, where certainly that's not even needed. You might get someone saying, stop coming to my room. I don't need you to come in every hour and remind me. I haven't forgotten, you know. So those are two different approaches. So programs and services, what's offered and how do we get those residents to those programs? What support is needed there. Also, the length of the programs and even the content of the programs is going to differ a little bit from a traditional assisted living, where perhaps a 2.5-hour movie after dinner is well enjoyed and everybody voted and wants to watch the Titanic, versus a program and service delivery and a memory support model where everything is a bit modified, and the programs aren't often longer than 25 to 30 minutes. They are often much more activity-based, hands-on, something like a fitness class or music therapy or even pet therapy, where there's this visual interaction as well as kind of a physical stimulation as well. And it's not something that would be perceived as passive, like watching a classic movie. So just examples and things that you would want to ask as you tour. Staff training is also something that's going to be different, right? So in a dementia-specific approach, you have to ask what training that individual or that team is receiving that helps them be prepared to care for someone who has a dementia diagnosis. So in a traditional assisted living approach, there's not this understanding that everybody under my care, everybody in this neighborhood has a dementia diagnosis. Actually, that opposite is true, that you approach each individual based off of their care plan and understanding their specific needs. And that person may have never been trained in dementia care. They may have never received any education on validation or redirection, or even any training therein within dementia. In a memory support neighborhood or a dementia-specific approach, each of those individuals has been trained in techniques for redirecting an aggressive resident or somebody who is experiencing maybe sundowning, or someone who has had very vivid hallucinations and needs to be validated and then redirected. That is all a very specific approach to care that is unique and, again, dementia specific. So that's not going to apply to all of these other non-dementia diagnoses. So although that training, I say, is beneficial for anybody, when you look at communities, you want to ask what specific training has your team been through if you're looking at a memory care model. A secure environment is definitely going to be a difference between a traditional assisted living and a memory support neighborhood. So when we're talking about traditional assisted living, again, this is an environment where that individual has that autonomy to say, you know, I'm going to go down to the salon and spa. I've got a 3 p.m. haircut. They may need help because they're in a wheelchair and they may need a staff member to help them get there, but they are not at a risk of leaving the community unsafely or not being sure of their environment or getting lost on campus or anything like that. I mean, they remember their appointment. They may even say, hey, you know what, I'm self-actualized to know the care I need. Can you help me push my wheelchair down to this area? So they're really structuring their own day, and there's not that risk or concern of them leaving the community unsafely. In a memory support model, there is the assumption that everybody has experienced some decline in their safety awareness. And so that can look at leaving the community unsafely. That could be a fall risk. I mean, there's this whole myriad around what creates a safe environment physically for that individual. But I will say most memory support or memory care communities are a secured neighborhood, meaning that it is a locked unit that either is fob access or key access. So whether it's, you know, electronic or hardware, there is staff members who can get in and out and family members who can get in and out, but that resident is being cared for in that neighborhood and will not leave that neighborhood without the support of a staff member or a family member or friend. So that would be a big difference and something to ask about. Is this a true memory support or memory care environment? Or is this a assisted living, but you have a lot of people who have dementia, which maybe that's not a secure neighborhood. And if that's something your loved one needs, you would want to navigate that and be very specific for what that means for that community. The last thing I'll touch on here in terms of differences would be staffing ratios. So even though the level of care is the same, we're talking about assisted living. And so the nursing team member staffing ratios would probably be the same between a traditional approach and a memory specific approach. When we're talking about staffing ratios, we're talking more team members than just nursing. So in a memory specific approach, you're going to have whether they're called activities assistants or life enrichment associates or any terminology therein, you're talking about a non-clinical team member who's there to guide and provide cueing and narration and some of those things we talked about earlier, where you don't have to be clinically trained to say, hey, may I provide you with some water? You know, it's been a couple hours since we've had something to drink. Or, you know what, let's go do that fitness class that I know that you love. That's not a clinical skill set. And so your neighborhood that you're looking at should have a higher ratio of these individuals than a traditional neighborhood, just for the fact that then a memory support approach, you're going to need more team members cueing, guiding, reminding, and bringing that individual through their day from program to meal to program, and helping, as we say, pull them through that day. How do we create an engaging schedule, recognizing that they're not remembering from, you know, breakfast this morning when we said, hey, this afternoon, we've got this great ice cream social. Well, that is not something that realistically they're going to remember. So in a traditional approach, they would. In a memory approach, you've got to have this higher staffing ratio to bring those individuals to those programs. So that's another question to ask. I'm going to take a quick pause, just look at the chat because I do see it counting up. We're going to try to answer those questions at the end. All righty. So I think many of us are on this webinar, right? Because we want to say we're looking at assisted living, but maybe we don't know when it's the right option, or we don't even know if it's the right option. We're looking for that clarity of how do we know timing? How do we know if it's the right level of care? So these are just a few bullet points. There are many, many more, but I think these are some of the most common ones that I've come across. So frequent falls, that is, again, not a normal part of aging. And so really understanding as you're caring for a loved one, or if you yourself are experiencing these occurrences, to recognize what things are a normal part and what things are not, so that you can say, you know what, if I'm experiencing a change, for example, a diagnosis like Parkinson's, where we know balance is impacted, and maybe the person you're caring for is having these frequent falls, which can often turn into injuries that need to be then clinically treated, that this isn't sustainable. And if it's a diagnosis like Parkinson's, it's progressive. And so understanding this isn't just going to automatically get better, or we're not just going to avoid a fall, that would be a good reason to look at an assisted living level of care, where there are team members who can support with getting therapy, right? With getting the right equipment, with maybe one level living is all it needs to be. A safer environment, maybe the bathroom is easier to navigate. So it's not that we magically prevent falls in assisted living or skilled nursing. Hopefully many of you are aware that there's nothing magic about the nursing team members, right? They're there just in the same way that you're supporting your loved one. They're clinically trained. So falls could still happen in a higher level of care, but there's a lot of safety nets that are in place there that are not in place in a home setting. So even something as simple as a mechanical bed that can be lowered, that if there was a fall, minimizes the negative impact of that fall. So there's all sorts of things that when you're looking at a care environment, change kind of the response and also hopefully the prevention. If somebody is falling because they have memory decline and they are getting out of bed to go use the bathroom, but they don't remember that they need help with that, that's something where you have, as part of their care plan, that team member coming in 30 minutes before or 15 minutes before that kind of usual time that their spouse has said, you know what, they always get up at 1:30 and that's when a fall happens. Well, then that team member is going in at 1:15 or 1 a.m. To help them to the bathroom preventatively. So it's kind of that prevention and then also the environment that can minimize falls. If meal preparation is difficult. So again, getting tired or just kind of slowing down, that's normal, right? But not remembering the steps of how to do something, or just overall kind of saying, I'm way too tired. It's not just a little bit tired. I don't want to grocery shop. I don't want to meal plan. I don't want to have to heat up anything even. I don't want to have to cut up anything. If those activities are so physically draining that an individual is then skipping meals, obviously that has an impact to their nutrition, to their hydration, to their overall status. It can impact how medications are interacting in their body. So something that seems so simple can end up being very much more difficult and cause things that could even, have them have to go to the hospital, right? So again, growing tired is maybe a normal part, but not to the point where you're skipping meals routinely or not able to contribute to your own kind of nutrition and hydration. Ability to navigate their current living environment. So briefly, we just talked about one level living, but that is another good reason to look at assisted living, to say, you know what, I'm 90 years old. I am not going to, outfit my house with an elevator or a chairlift or these other things. I want to be with other people who are in my season of life. I want help while showering. I want med management, and I don't want to outfit my current house to make it safe for what I need. I'm now dependent on a wheelchair or dependent on a rollator. My bedroom is on the second floor. I need to pursue a living that is one level. So that's another good reason to look at assisted living. Help needed with activities of daily living. So we kind of talked about this in that earlier slide. Certainly bathing, med management, meals, these are top reasons for looking at assisted living and saying, you know what? It's not that I couldn't get help with each one of those in my own setting, but at the time that you start kind of adding them all onto each other, you think, am I going to have a registered nurse come out to the house weekly and set up my pills. Once they set them up, can I safely take them without assistance? Am I going to bring a nursing assistant, 2 or 3 times a week to my house just for helping me bathe? Am I going to bring a nursing assistant to help set up those meals? Or maybe it's just a housekeeper who can help set up meals as well as clean the house. I mean, how many different ancillary people are we trying to bring into the home to create this assisted living environment? Certainly an option. There's ways to do that, but there's also a time where you say, you know what, I'm bringing in so many people and it still doesn't meet my social needs. I'm going to look at assisted living. So it's another good reason. And then we've already talked quite a bit about medication management, the dangers that are certainly present when it's not handled appropriately, and then how easy it is to have this done in an assisted living setting where you have a registered nurse who is licensed to be able to provide medications. That's something that a caregiver or a companion through an agency is not licensed to do. So even if you're staying in your home setting, they can prompt or they can cue you, but in order to set up the pill box or to distribute those medications, you really do need a higher level of licensure than just a caregiver or a companion or a certified nursing assistant. So these are all good reasons to look at assisted living level of care. So let's tack on to that. We've talked about assisted living level of care. What would be a good reason to look at a memory support or a dementia specific approach to care? Again, still at the assisted living level, but what are maybe some of the things that we see that would indicate we should be looking more towards a memory care approach? So all of the things we already mentioned, but a couple more. So safety and isolation concerns. When you're experiencing neurocognitive change, you are not taking that initiative to call up a friend and have a good conversation, to remember that your specific grandchild is going to call you on Tuesday nights and you want to be near your cell phone to answer that, or to remember which program you like on TV, or remember how to access that program. So there's so many things that somebody may be able to navigate, even if it was virtual spaces for engagement and socialization, that start to diminish once there's a neurocognitive change. And so you really do have adult children or a spouse who's playing this role of entertainer and social worker, trying to make sure we're not forgetting appointments. What are we doing that's engaging? Can we set up with a crossword puzzle? Oh, now I should turn on a TV show. Can I think of a neighbor who might want to walk with them? And you're really trying to plan out their day for them to be engaging, because this is something that they've have a decreased ability to do for themselves. Cognitive decline is present. So that's a really easy one. If we're saying, you know what, there's a diagnosis here, we know it's progressive, we know it falls under that dementia umbrella, we shouldn't just be looking at a traditional assisted living approach. We should be looking at a dementia specific. And so that is, whether that's, again, Alzheimer's or advanced Parkinson's, or Lewy body dementia or frontal temporal lobe dementia, there's any form or diagnosis of a dementia, that would be a good reason to look. Social engagement concerns. So we kind of already mentioned this about safety and isolation. We want to have stimulating programs that have been adapted and are appropriate for where this individual's change has taken them. So we kind of talked earlier about watching a 2.5-hour classic movie that might really actually be riveting and engaging for one population, but simply just be too long and not relevant anymore for an individual who's experienced neurocognitive change. So specific programs that are socially engaging and living life with other individuals who've also experienced that change. And so there is not that repetitive conversation at dinner that's frustrating to someone else because it's as new to them as it is to the individual who's sharing some part of their life story. And so social engagement within a specific memory support neighborhood is going to be different than within a traditional model. Also safety, which I guess we kind of jumped over, but looking at that secured neighborhood that we talked about earlier. A dementia specific approach to training of the staff, we kind of talked about that already. That is very specific and different from just a traditional model, and a very good reason to look at specific communities and say, I love that they are committed to everybody being a certified dementia practitioner, or that they bring in XYZ individual every year for training, or that they have 8 hours of education with the Alzheimer's Association every year, whatever that is that checks the box for you to say, you know what, those team members are treating my loved one in a way that is specific and helpful and conducive to their care, as opposed to just kind of living in this oblivion of not really sure how dementia has impacted your loved one. And then the secured environment. So whether that's electronic or mechanical. What does it look like to have an environment? And then beyond that's secured, then beyond that, are there safety nets of security officers on campus, concierge desk, asking through kind of all those questions. What is their process for knowing the residents in the neighborhood who are elopement or wander risks? All right, so navigating your options. I mentioned in the very beginning that my work as a contract dietitian brought me into many different communities and many different settings. And even now in my current role, I'm often collaborating with other communities for educational events, for training, for hosting different things. So, you know, in this area, we are lucky. Montgomery County, DC, Northern Virginia, there are so many resources for education, for senior living. And so it's a blessing to be in an area where there's great communities. And so I can just tell you about a couple different types of communities, so that as you're doing your search, whether that's a Google search or that's, you know, boots on the ground and you're going to different communities, what are you asking about? And for you to be educated to know what type of community are you looking at? So one of the ones that I think is just very, very common is a freestanding assisted living community. So what that would mean is that it does not offer independent living, nor does it offer skilled nursing facility. It is just an assisted living level of care. And so they may not even have memory care or memory support services. It's just truly assisted living. That has, in many, many communities, merged or morphed into this second bullet point, assisted living and memory care communities. So with this need that has increased over the last 20 years to serve more individuals who have neurocognitive change, many of those freestanding assisted living communities have opened memory support specific neighborhoods. So that is a very common option, to find an assisted living level of care that both has a traditional model and a dementia specific model. They, again, do not offer independent living. They do not offer skilled nursing. It's just assisted living. Some of these have started to add independent living. That's a non-regulated level of care. That is a much easier thing to do than to add skilled nursing, which is a highly regulated level of care and a very difficult level of care to run and to, you know, create or to add onto your campus. That's something that would be very, very intentional. So not as common there. Another option is small group homes. So this is exactly what it sounds like. They're often in residential settings, and they house maybe 8 to 10, maybe 12 people. I would think maybe about 16 would be a max. So this is a small network where it's at the assisted living level of care, and it is a residential setting. So your loved one is living with, usually it's about 8 other people or 7 other people, and they're having meals together, and their medications are managed, and there's nursing staff to help them, but they're living in a home. So that would have to be a very specific thing that you say, you know, I know that this is best for my loved one, because in my experience, you're not going to have access to multiple dining venues, to a pool, to, you know, lecture series or concerts on campus, or any of that kind of other cultural arts aspect that many larger communities are going to have. So that is a very specific approach. And then the last one would be life plan or continuing care retirement communities. So that is a community where you have each level of care on campus: independent living, assisted living, and skilled nursing. And again, this doesn't stop at just independent and assisted. Having that highest level of care, that skilled nursing facility that is very difficult to run, to have all 3 of those on one campus is what makes something a life plan community. So those are just 4 options as you're looking at communities, identifying what type of setting you think is important to your loved one, or where you think they would thrive, which one gives you the most peace of mind and security, and then knowing what you're actually looking at and asking those questions. Do you have a skilled nursing facility on site? Or maybe a pool's not important. So you're like, you know what, a group home is fine because I don't need multiple dining venues. I don't need a pool. I don't need all of those services and amenities. So understanding your loved one and then pursuing a community that lines up, that meets their needs. So specific type of community, we talked, the 4th bullet point was life plan or CCRC communities. Often these are not for profit, not always, but often they are. Often there's a religious background to that community that has, for many communities now, become interfaith. or non-religious, but there's those roots of maybe a Methodist community or a Presbyterian community, or maybe it's a military community, but there's an organization there that has kind of given it that foundation of being a not-for-profit community. And then the structure there is this reporting to a board of directors and this vision and mission that's probably a little bit more comprehensive than just a standalone assisted living community. And so there's this goal and desire to care for the people who live in that community through the whole continuum. So whether they enter as young 70-year-olds who are looking for a social and engaging lifestyle, and then their needs change and they need assisted living, or they end up right off the bat saying, you know what, I've got these progressive diagnoses. I know that I need skilled nursing, whatever those care needs are, or if it goes through the whole continuum, it's all available on one campus. And there's a huge peace of mind there to not have to think, I need to move again in 5 years. Or if I develop a specific disease, I would have to move. Know that every care option is available on that campus. So that's the life plan model. Again, there are not-for-profits and for-profits. One of probably the easiest ways or the fastest way to kind of diagnose that is while you're doing your searches. If it is a .org, their website, it's a good indicator it's a not-for-profit. If it's a .com, it's a good indicator that it's a for-profit community. Just a little trick of the trade as you're doing your searches. So not-for-profit life plan communities, that's actually where I work now. That's what Ingleside is. So it's certainly what I'm able to share the most about. So at this time, I'm going to kind of transition into talking specifically about this type of community setting. And then certainly I'll save a little bit of time at the end to tell you exactly what Ingleside's approach is to memory support services and programs and traditional assisted living and what we have available, who our team members are. Another thing to think about when you're looking at a not-for-profit community would be a supporting fund. Many of them have a foundation that's available to their residents for life. So to say, we want to keep you here, not just for your clinical needs, we want to care for you, but financially, if your situation were to change through no fault of your own, our community has a foundation available to support you and keep you here at the community. And so that's very unique to not-for-profits and something to ask about as you're doing your community tours. If you're specifically looking only at not-for-profits, specifying what are the criteria for the foundation, does somebody have to live there for a certain number of years? You know, how do you secure your loved ones' ability to stay in that community, both clinically and financially for the rest of their lives? Often in a not-for-profit model, the revenue of the community is reinvested back into the community, which is wonderful in terms of updates on campus. So everybody wants to enjoy a new service or amenity, a beautiful salon and spa, or a state-of-the-art fitness center, or like we mentioned earlier, multiple dining venues, or an indoor pool, or converting a pool from chlorine use to saltwater use. You know, what are the things that are updates on campus that you want to live in a campus or in a community that's consistently becoming better and bettering themselves? That's often more possible in a not-for-profit community. Endless opportunities for engagement. And so this is really cool in terms of looking at independent residents who have volunteer opportunities in skilled nursing, or independent living and assisted living residents who are participating in life in our memory support neighborhoods, investing in others. There's always this opportunity to, whether it's volunteerism or just maintaining those friendships across multiple levels of care. That's not going to be present in a community that is only one level of care or one approach to care. We kind of talked already about lifetime housing. No matter how those clinical needs change, to have the right structures on campus to be able to care for those changes. And then certainly friends and neighbors for life. So if those needs do change and you or your loved one finds yourself in a different level or approach to care, you haven't lost your friends from independent living or from assisted living. They're still able to visit you, or you go to the dining room with them, or just continue those friendships that isn't going to be possible if you have to move out of a community, or it's much harder. There's barriers there to continuing those friendships when you have to move to a different community. So we talked a little bit earlier about Google searches and looking for communities. That's where a lot of us start these days. We get online and we start looking at things. My first choice, best choice, always a referral. If you have a loved one who's navigating some changes, whether it's neurocognitive or physical, if you can ask a friend, or if you know someone who's been through something similar, or maybe your partner has gone through this with their parents, How do you get a referral? You know, where do they live? Is it close? Is it in this area? Can you say which communities do you recommend? Hands down, best way to find a community is who do you know and trust that has been there or experienced their care and can refer you to them. So that would be my top choice. There's also some other great choices, things that make it easy that you don't have to do all your own research. So maybe you're a data person and you think, I want to create an Excel document and I want to line up, you know, row after row of exactly what I'm looking for. And then I'm going to go column by column and give out all these places grades. Maybe that's what you enjoy. But if you'd like somebody else to have done that work for you, that's what the Guide to Retirement Living Source Book is. So looking at community after community and multiple different zip codes and areas, defining it by how much it costs or what amenities are on campus. So don't do that work for yourself if you don't enjoy it, because that's already been done for you. Senior living navigators. So these are places like A Place for Mom or A Family Tie or caring.com. These are kind of network resources where they say, okay, let me hear about your loved one, and then I'm going to push your information out to a handful of communities that could be a good fit. And so that saves you time because you have one conversation instead of maybe a dozen conversations. And then those individuals come to you to present what their community can do for your loved one. So that's another option. And then, oh gosh, I don't know if this is my second choice or my first choice. This is going to be my second choice, but it's such a good one and right up there with a friend referral or family referral. Geriatric care managers. These are individuals who are often retired social workers or registered nurses, individuals who have spent their entire career in senior living or in community services or aging services, and they know everything. I mean, they can tell you which communities have which team members who are excellent, what the staffing ratios are. Their experience and knowledge of these communities often goes back years. And so they're telling you, you know, this is the management company or this is how they do business. And so these people are a wealth of information. I refer to them liberally. In addition to their knowledge of the industry and helping you find a community, they also have clinical backgrounds. And so they're able to hear about your loved one and say, you know what, that is a great community, but they're not an option for you because they're only independent living. And yes, they have a great reputation, but your loved one needs long-term care or whatever the need is. And so I'm kind of getting a 2-for-1, somebody who can help you with industry experience and clinical experience is wonderful. So geriatric care managers is another resource. And there's some great ones in this area. So again, like I said earlier, we live in an area where there's so many great resources for helping you on this search. Something to talk about briefly, and I say briefly because it's going to vary from every community, but is the cost of assisted living or a memory care approach within assisted living. Inevitably, in all of my experience, once you need that memory care approach, it's going to be more expensive than a traditional approach. And that makes a lot of sense. We've already talked about the investment that goes into staff education, the higher staffing ratios, even just the layout of the neighborhood, things like it being electronically secured. These are all going to make it more costly. So to set your expectation that if you're looking for a memory care approach at the assisted living level of care, that's going to be more expensive than just a traditional assisted living approach, just to set your expectation. Types of communities, you will hear about rental communities. You also hear about entrance fee model communities. So a difference there would just be often life plan communities or continuing care retirement communities have this large entrance fee up front. That's kind of your security into the community. Often those contracts are 90% refundable or 50% refundable. So you're saying, I'm putting down this large entrance fee to gain access to this peace of mind and this structure where every level of care is on one campus. And then at the time that I were to move out or pass away, my estate or my family is receiving that portion back, whether it was a 90% refundable or 50% or whatever that contract type was. So that's one model, that's the entrance fee model. There's also communities that are straight rental model. So you're not paying that large entrance fee. You'll see that rental model a little bit more often when it's not a life plan community. Something to be very specific about when you're looking at the assisted living level of care. Is it a fee for service or is it a bundled fee structures? Another way to think about this is a la carte for each charge. So maybe room and board is $7,000, but if your loved one needs level 2 care, that's actually another $1,500. So now you're at $8,500. If you need medications, well, if it's less than 5, then maybe that's $500. But if it's more than 5 medications, now we're looking at $1,000. And so that kind of a la carte processing of your bill or your monthly statement can be challenging. And so being prepared, is that the kind of approach that I would like, and to kind of assume that I'm going to hopefully get in at a lower amount? Or do I want to look at a bundled structure where, as long as it's within the assisted living scope of care, your loved one is cared for at a bundled rate, where med management and room and board and 3 meals a day and nursing care and programming and incontinence supplies is all part of one flat rate. And that's certainly going to come out a lot closer to probably a $12,000 or even more for a monthly fee, versus maybe a fee for service that'll start much lower, like a $7,000 or an $8,000. A private pay versus insurance covered, just to mention this briefly, to say, to set your expectation that an assisted living level of care is almost always private pay. There are some communities that have pursued the Medicaid waiver. So that would be an insurance for low income individuals to cover their assisted living care. Those are pretty far and few between. Most traditionally, assisted living is private pay. So often somebody might say, well, I have Medicare. That is not a payer source for assisted living. Part B would cover outpatient therapy. So you could live in assisted living, privately pay. And then Part B would be covering you visiting a physical therapist, or them coming to your apartment twice a week. Or Medicare Part D would continue to be billed for your medications, but that does not cover the room and board and all of the stay of assisted living. We just briefly mentioned that Medicaid, so that low income payer source, is almost off. I don't want to say always, but it's very hard to find an assisted living community that accepts Medicaid. Much more often, you're going to find a long-term care community. So that's that highest level of care at a skilled nursing facility that accepts Medicaid as a payer source. And then lastly, long-term care insurance. So this is something that you or your loved one has invested in. That policy can start at the assisted living level. So that's an important nuance, because it is not going to start at an independent level. There's no clinical needs there. Or even if there are needs, they're not recognized again unless it's maybe a home care provider coming to you. But if you're talking about the whole rate being covered, as long as you meet those qualifiers, often it's 3 activities of daily living. That box is easily checked through med management, meals, a steady hand while showering. Then that long-term care insurance would then cover an assisted living. So again, just a couple more things as you're choosing a community, things to think about, to ask, and we've talked about most of these. What is the size of the community? Is that the right fit for my loved one? We talked about a life plan community, which is inevitably going to be much larger with an independent assisted living and skilled population, versus a group home, which is on that small size. Within assisted living communities that are just standalone assisted living, they can be small, 1 or 2 floors, or they could be multiple floors where everybody has that same kind of need or level of care, but it's still hundreds of residents because it's multiple floors. So what size is right for your loved one? What levels of care can be provided? I would really hone in on this one if your loved one already has a progressive diagnosis, because if you're looking at just a standalone assisted living community, but your loved one already has a dementia diagnosis, then you need to be looking at a community that also has a dementia-specific approach to care. It's probably a separate neighborhood, but let's make sure that that community offers both, because you already know something about your loved one's future care needs or how that's going to change. When you're looking at kind of a clinical need, so maybe the question is, what happens when Alzheimer's progresses and my loved one is actually totally dependent on nursing care, like what I talked about in the beginning, where you're actually in need of skilled nursing care. If you're only looking at an assisted living community, what is the plan there for when your loved one needs that higher level of care? So what levels of care on campus? How big is that campus? What type of living accommodations? So typically in assisted living, when it's a traditional approach, you can find a whole variety, 1 bedrooms, 2 bedrooms, studios. Most memory care approaches are going to have studio apartments. That's really an acknowledgement to that individual's diminishment and safety awareness, and even just how much easier it is on them to navigate a smaller space and to really be spending their day with staff in programming areas and not so much isolated in their room. Monthly fees, we just talked about that. Is this an a la carte model, or is it more of a bundled model? What's your preference? And what can your loved one afford? What services are provided? So there's certainly some basic things that should be consistent between any assisted living community, but then there's certainly communities that are doing extra things. So what are those extra services? And to ask them that, you know, I know that assisted living is a regulated level of care. I know you're required to do X, Y, and Z, but what are the A, B, and C that makes you unique? And so asking the community that. What are their ancillary fees? So what are the things that if they have a bundled rate aren't included in that? Or if they tell you, you know, we're a la carte, but so much is also included. Well, what are the things that are not included, and understanding exactly what that is. You can ask for a copy of that resident agreement or contract ahead of time if you want to read through that. Not-for-profit communities are going to have a disclosure statement that they can provide to you. You can ask the community for their copy of their latest state survey. So again, I've said multiple times that assisted living is a regulated level of care. That means that the local jurisdiction comes in and reviews that level of care. So what was the outcome of that review? And then of course you want to ask about staffing ratios, both clinically and socially. Who are these other ancillary team members who are help guiding your loved one through their day? So in our last few minutes together, before we open up for questions, I just want to introduce you briefly to the Ingleside communities. Again, we are a not-for-profit life plan approach. So our communities have independent living, assisted living, and skilled nursing all on one campus. And then our communities additionally have memory support or dementia-specific approaches to care at each community. So at our Ingleside at Rock Creek community, we offer that service in assisted living. At our Ingleside at King Farm community, we actually offer it in all 3 levels of care. We have a social day program that meets the needs of our independent living residents. We have a memory support approach in our assisted living, a residential option. And then we also have a memory care wing within our skilled nursing for individuals who have those total dependence needs, but also have that dementia diagnosis and need that specific approach to their care. Westminster at Lake Ridge is our 3rd community in Lake Ridge, Virginia, and they have a memory care service specifically at the skilled nursing setting. Another thing to ask about at other communities, and certainly something we're proud of at Ingleside, is to have done well in our surveys and to have notable mentions within US News and World Report. And this looks at things like therapy success, best practices in clinical care, customer satisfaction. There's multiple kind of points of rating there. Looking a little bit closer at Ingleside's approach to memory support or a dementia-specific approach to care. So we've spent almost our whole time together talking about what does this mean or what should it mean. So at Ingleside, for us, it means having a very specific well-being centered approach to that individual's care, where we are highlighting their desire to have a meaningful life still, even though so many things have changed for them. What can we learn about their past or their career or their family or the things that were important to them? How do we highlight those moments for them? We want to see what was important to them then, and then how can we bring that into the present? And if those desires have shifted, which often occurs, then what new things can we introduce that have each day being filled with engagement, whether that's socially, physically, emotionally? How do we have a full program that helps each individual feel like, wow, today was meaningful or today was fun? That's our goal. Our specific well-being philosophy, again, authenticity, right? So we want authentic living where things that were important to somebody continue to be part of their care plan, where we're acknowledging who they are specifically, not just seeing them as another individual with a dementia diagnosis. Again, that is closely related to many of these other points: purposeful living and autonomy. What can we highlight? What can we learn from their representative, their loved one, who their care provider was? What can they teach us about who this person is and the care that they need? And then how do we replicate that and highlight for them the things that are high points for their day? Each individual feeling connected and being seen. So this is Ingleside's specific well-being philosophy. We want to know each person. We want to meet them where they're at. One of our memory programming directors, who I'm just going to briefly in the next couple slides introduce you to, she always says we see past the dementia to the person. And that is absolutely true for the approach to care at the Ingleside communities. A couple bullet points I'll try to run through pretty quickly. Beautiful new spaces, our memory support services and programs, buildings, and those residences were all designed and built in the last 5 years. So that's great to have new amenities and spaces. They're beautifully designed, high ceilings, a lot of natural light. In terms of looking at our clinical team, having person-directed care plans, that input from so many different team members, the director of nursing, the social worker, the dietitian. It's this full rounded care plan for your loved one. That integration of our well-being philosophy, so that specific approach to, again, seeing past the dementia to the person. I talked earlier quite a bit about dementia training. We do require that all of our team members be certified dementia practitioners. So that's an extensive amount of dementia training for that individual to have those tools that are necessary to care for your loved one in a constructive and safe way. High staffing ratios. So when you look at a norm for assisted living, that's probably a lot closer to 1 to 12. In our memory support approach, we've got much closer to a 1 to 6 ratio, because it's important that we have those additional team members who can help guide your loved one through the day. We talked earlier about being a not-for-profit organization, to be mission-driven, putting those resources back into the community, having a foundation that is intentionally growing every year to be able to care for residents who may outlive their own resources. We've talked about having skilled nursing on campus so that if your loved one's needs change, where clinically they've actually got some chronic diseases that now need quite a bit of management, or they're very dependent on nursing care, that they don't have to go find a new community, that they can stay within the Ingleside community and move to skilled nursing. We've talked about direct access to a lot of amenities on campus. Our independent living communities do have on-site clinics, and so those are spaces that can be used throughout the continuum, where you could choose a provider that has their office space here at Ingleside, and that provider continue to see you through each level of care. We have the therapy gyms on site, beautiful salons and spas, so it's quite a bit of, again, that services and amenities lifestyle that's available often in a life plan community. And then I talked earlier about a la carte versus bundled rates. Ingleside features a bundled rate, and so that is, again, where all of those needs, the room and board, med management, meals, programming, even incontinence supplies, is one monthly charge. So you, as the resident representative, spouse, adult child, you are receiving one statement that has one amount, and then we're very clear and upfront with what our ancillary charges are, such as a guest meal in the bistro or a haircut. And so you would very detailed see what items are not included in that bundled rate. Quickly, I'll introduce you to our memory neighborhoods at Ingleside at King Farm, our community in Rockville, Maryland. We do have 2 floors of residences. They each have 16 studio apartments on each floor. And so that's 32 total. And when you think about size of a community, you're getting kind of the benefit of the clinical team being very focused on your loved one, only 32 residents, very intimate care there, but then part of this much larger life plan community where you can enjoy all of those amenities we've already discussed and those relationships. I want to introduce you to Maureen. She is our memory programming and services director for our Ingleside at King Farm community. She's a wonderful professional, years of experience with the Alzheimer's Association. She's delivered some great educational programs in collaboration with me to be able to benefit you and other families who are looking at our communities. So she's an incredible resource, but also just to make note that that's something that is unusual to Ingleside, to invest in this role and somebody of this caliber. It's not a regulated or required position to hold. And so for our communities to invest in having somebody like Maureen on campus is a huge acknowledgement to our commitment to staff training, to innovation and programming, and to having really a specific point person for our memory neighborhoods. And again, of course, I would love you to look at Ingleside, but as you're looking at other communities, ask if they do have this specific person beyond a social worker or a life enrichment associate. do they have somebody who is breathing that fresh life into the programs and doing staff education? I'll put actually in the chat just a video where you can click on to meet Maureen virtually. This is the standard studio at our Ingleside at King Farm community, something that we would have available if you wanted to schedule a tour and look at what is here on our campus in our memory support neighborhoods. I want to introduce you to Ingleside at Rock Creek, our community in Northwest DC. Very similar layout as opposed to 2 floors. It's actually an east and a west wing, 16 apartments within each wing, 32 apartments total. Very similar structure in terms of intentional outdoor space, the common areas being the focal point where each apartment opens up to a common area, really lowers that barrier or threshold to engaging in programming, coming right out of your room and saying, oh, what's going on here, is a great way to start your day. Mariana Blackburn is our Memory Services and Programming Director at Ingleside at Rock Creek, another incredible individual who is so dedicated to caring for individuals with a dementia diagnosis and really caring for their families as well. I don't have a YouTube video to share with you for her, but I am just going to take 1 minute and read a quote from Mariana. She's actually going to be featured next month. We're going to do an educational program together. I'll make sure I share that with each one of you so you can join us. But let me just share with you how Mariana approaches care. She says, my work centers or hinges on the idea that here in memory support assisted living at Ingleside, we look beyond the disease to the person. What does this mean and how do we connect with our residents living with dementia? Dementia does not define the person or tell us who the person is. The person tells us who they are through their lived experiences. We design and deliver programs that nurture imagination, help residents to remember, and support our residents' abilities to express themselves. So again, next month, we'll actually be featuring her talking about her work in storytelling conversations as a therapeutic approach to care within memory support. This is an apartment that's available at Ingleside at Rock Creek. It's a larger studio, courtyard facing, again, something that if you wanted to reach out and see our communities, this is something I can share with you. So lastly, I just want to let you know that we do offer respite. Not all communities are able to do something like this. For us, it's a 30-day trial stay. It can be a respite for the primary caregiver to be able to say, you know what, my loved one, I'm committed to caring for them, but I need a break. I'm trying to go see my grandkids that are in California, or I'm trying to get a shoulder surgery scheduled, whatever it is that makes their life need this option. We do offer a respite program in our memory support neighborhoods. In our traditional assisted living as well, as we have availability, we're able to do this 30-day trial stay. So we'll end here. Why make a move to a supportive environment? Socialization and intellectual stimulation that's appropriate and modified to that individual's abilities is a primary reason. Professional and compassionate support when needed. We talked about the ability to bring people into the home setting, but are you truly going to get all of the care team members that you get at a community? So again, that director of nursing, the social worker, the life enrichment associate, the fitness instructor, the chaplain, the team is a lot larger when you're in a community than what you can feasibly bring in individually into a home setting. You're able to maintain independence. And so when you're looking at an assisted living level of care, that is really that sweet spot in terms of tuning into independence. How do we support your loved ones? Autonomy and decision-making by also giving them that additional ancillary care that they need, as minimal or as much as it is to have that safe lifestyle. We talked about nutrition and hydration and the importance of 3 meals a day and not having to do that work. There's things like transportation. We didn't even talk about it, but most communities are going to have so many services and amenities and programs on campus, things that you find yourself doing for your one that are now taken care of. When you're specifically looking at a not-for-profit community that has a foundation, you are looking at an investment to be able to say, this is where I'll be for life, and I am cared for, and I have that peace of mind, opportunities to pursue a healthier lifestyle, So it's a very specific model. And then of course that security of the foundation to be able to stay in that type of community, which is peace of mind for your loved one and for you, the family. So I can also share these slides. I know some of you might be trying to write all this down, but I can share these with you. And that kind of wraps us up for today. So what we're going to do now is jump into some questions. So if you've hung around for questions, we're going to do that now. And I'm going to open up the chat. So one of the first questions we received is if I personally am the individual who does the nursing assessments. I am not. I work with our clinical care team for that. I do our education and our introductions to the communities, but I do not do the nursing assessment. Another question was how much is the entrance fee for Ingleside? So that is specific to each Ingleside community. And that would be something to call in specifically to the community, or certainly you can reach out to me afterwards and I can share with you depending on the community you're looking at. I will briefly say that in independent living, we're talking to about an entrance fee that's comparable to an asset like a property. So that kind of anywhere between maybe $550,000 to $1.5 million or more, depending on the size of the apartment. When we are talking about assisted living, it is a very different entrance fee model. Ingleside at Rock Creek, our community in Northwest DC, does not have an entrance fee for assisted living. Ingleside at King Farm, the community in Rockville, Maryland, has a very small entrance fee, and it's 100% refundable at the time that the resident were to pass away or move out of the community. So very different models for each type of community, but you're certainly welcome to reach out to me individually for more information. Next question, if a spouse does and could continue to take care of his or her partner, but is draining option that is increasing, is assisted living a better option than memory care, especially if memory care housing is studio size? That is going to be so specific to each individual. One of the best things I can recommend is to engage either if you have adult children or a geriatric care manager or your loved one's primary care provider to weigh in on this discussion. What is the toll to you as a primary caregiver? Is if your health is impacted to the point where you might not actually be able to endure caring for your loved one in this way, then that is not a good service to continue doing it in the home setting and then expire yourself to the point where you're not able to care for them at all, not even as a friend or even potentially be in their life anymore. And so as dire as that is exactly what can happen if you wear yourself down emotionally and physically by doing this 24/7 caregiving to the point where you're not able to even be in your loved one's life. And so that is only something that you can talk about with your family or with your provider to say, what's the toll that this is having on me? Should I be looking at a different care model? If you are looking at life plan communities or you live in a life plan community and you are able to reside in independent living and you have access to a memory care or a memory support approach, that may be the very best answer for you because you're able to still be on the same campus, spend meals together, be more of that friend and partner and less of the hands-on caregiver, social worker, nurse to your loved one. Next question, does a 1:6 ratio mean 1 resident to 6 staff or 1 staff member to 6 residents? I like a world where there is 1 resident to 6 staff. I could use that right now. I always tell my husband, I wish I had a wife because I could use that kind of help. But no, that is not a 1 to 6 staff members. That is to say that we have 1 team member to every 6 residents. And so when you're looking at clinical, again, or social, you want to ask those questions. Who are the team members for our communities? We have dedicated staff at every single department to our memory support neighborhoods. So to have a housekeeper who knows all of the residents and who's always in memory support, to have a dietary aide who knows the residents, who's always assigned to memory support, to have the same nursing team members, the same certified nursing assistants, the same licensed practical nurse or med management nurse, to have all of those same team members, the life enrichment associates who are all part of our memory support approach, all trained as dementia practitioners. And then that is what contributes to our staffing ratio. We've got a follow-up. I should have said memory is the issue that affects everything else, medications, et cetera. Yep, that's understood when we're talking about neurocognitive change. 2 more questions. Is it possible for someone who needs skilled nursing care or the highest level of assisted living care to live in the same unit with someone who needs memory support. So possible would mean that they are both in independent living and you're bringing in the care team members to support those needs. If you're looking at a life plan community that has all of those options on one campus, then one individual is living in skilled nursing and the other individual is living in memory support. And so those are two separate residences on the same campus. I think that answers your question. The last question, will you send out the links to the videos that you share in the chat? Yes, we can send out all of this information. So I think that is it for questions today. Thank you so much for joining us. If there's something that we didn't get to or didn't have time for today, then you're welcome to email me directly, or you can call or text me. I'll tell my cell phone number. It's 202-489-1416, and I'll be emailing each one of you to share the link for today's recording, and probably sometime the next week. And so when I do that, you can also look at my signature line and see my cell phone number there as well. And you're welcome to call or text me to follow up on any of this. So thanks so much for joining us today. Have a great rest of your day. And thanks so much for your interest in Ingleside.